Ethical Considerations for Using Seclusion and Restriction as a Method for Treatment, written by Megan Foltz. Controversial topics are said to always have a gray area whereby individuals can find some sort of agreement between the two polar sides of a topic. However, for many people, their opinion might be black or white. In other words, there might not be a common ground, but rather an individual might have a strong opinion to one side of the argument or another. While I can see both sides of using restriction and seclusion, for the sake of the assignment, I chose to take a stance against seclusion and restriction. The use of seclusion and restrictions pose several ethical violations in the practice of treating individuals who are both typically or atypically developed. One example where an ethical violation could arise is if a child is placed in a timeout area or secluded from the classroom during educational hours. The right to education is therefore violated, and it also limits the opportunities of social engagement and the development of social skills. A form of restriction that is most often severe is restraint. The reason that this is so severe is because you are physically holding down a client, which could cause extreme harm to their physical well-being. Another form of restriction is the restriction of daily activities and opportunities. If a behavioral program suggests that you restrict access to certain items or leisure times, the client is not afforded the same opportunities as the rest of other humans. Also, medication can also be a form of restriction. While it is quite often that clients are given medication to suppress their target behaviors, one needs to consider that medication can restrict them significantly. The medication is causing them to be drowsy or causing a side effect that is also harmful to them, then maybe we should reevaluate the usage of a medication and realize how much it could be restricting them from living a normal life. Restriction and seclusion are in several different settings, such as hospitals, school systems, and also in prison settings. For example, in the prison setting, restriction is an everyday formality. Clients are always secluded to their cells and restricted from even going outside of the prison walls. While this is what most people think that they need as a form of punishment for the crimes that they've committed, and therefore their rights are taken away when they decided to commit the crime. However, there's no evidence that suggests that this type of punishment will work in reducing those crime behaviors. This paper will review the history and literature surrounding seclusion and restriction and how using these methods for treatment can negatively affect the client's overall well-being. We will also discuss alternatives and the need for standardized regulations of seclusion and restriction. There have been several cases within the history of treating individuals both atypically and typically developing that have led to severe mental, emotional, and physical harm, and in some cases, deaths. One of these cases that resulted in severe abuse was the Sunland, Miami scandal. There was severe abuse and neglect as a result of the staff's implementation of quote-unquote behavioral interventions. Examples of their interventions included using restriction for punishment rather than for emergency and secluding clients to a bathtub for approximately 2 days. Once light had been shown on these events, the Blue Ribbon Committee was formed in order to evaluate scenarios and compile ideas on how to protect clients from harm. To add, Zirkle and Lyons, 2011, compiled an empirical analysis of case law and reported occurrences where individuals with disabilities were restrained, and even after stating that they could not breathe, the restraint was still continued. While the cases like these are sad, and the clients of these cases were both neglected and abused, which resulted in a great deal of harm for the clients, cases like these have paved the ways for laws and standards for both research and clinical practice with humans in order to protect their overall safety and well-being. The very first case that ever dealt with helping with the rights of individuals with disabilities was the Youngberg versus the Romeo case, in which the Supreme U.S. Court stated that individuals who are in a state of institution are to be guaranteed rights to reasonably safe conditions and have freedom from unreasonable restraint. While this was one of the first laws created for individuals with disabilities, still today there's no formal regulation on the standardized methods of restraint. To add, Villani, Parsons, Church, and Beater compiled an article to give readers a descriptive analysis of the use of restraint and seclusion in school systems where the majority of students had autism spectrum disorder. However, before analyzing the methods, the authors gave background information on the laws that were created to protect individuals from seclusion and restraint. According to Villani et al., the Education for All Handicapped Children Act, now better known as the Individuals with Disabilities Education Improvement Act, IDEA, this law required staff to find or create methods to safely address aggressive or self-injurious behaviors of students. In addition, while there have been committees formed and laws created to protect clients, according to Smith, Katsianis, and Bryan, there are currently no standardized procedures to monitor the usage of restraint as a restrictive procedure nationwide. To add, Bernard Brack, Au and Louis, 2014, stated that reported restraints that were implemented with improper use have resulted in serious death and injury in several settings. The authors also state there is not a current legislation that regulates the usage of restraint. While laws and regulations are limited on the usage of restriction and restraint, in the field of behavior analysis, Bailey and Birch, 2011, created a book that is compiled of guidelines to follow as a behavior analyst. The authors give readers a variety of topics to consider when practicing in the field of behavior analysis. They provide the behavior analyst with several vignettes in which the behavior analyst might be put in a position where there could be an ethical dilemma. This allows the reader to use the material in the book to determine how to address the situation in an ethical manner that does not violate the rights of the behavior analyst or the client, and most importantly, how to prevent harm. They also provide users with a chapter in the book that specifically addresses behavior change programs, which is guideline 4. In this chapter, the authors attempt to provide behavior analysts with guidelines to follow when practicing in the field with clients. The authors state the necessary and salient aspects of behavior change programs that need to be carried out when implemented. One important feature is when to terminate the behavior change program. The authors state that there is a large degree to which a clinician uses what they call clinical judgment when making the decision to terminate a treatment. However, to prevent harm and to prevent an ethical dilemma, they suggest that the guardians and the client, most importantly, be involved in the process of terminating a treatment. To add, they address least restrictive procedures as well. They state that the behavior analyst should always recommend the most least restrictive procedure for a behavior change program, as it is still likely to be just as effective. This is a good step for the field of behavior analysis in the attempt to regulate restrictive procedures. However, even so, these are only guidelines for behavior analysts. And as stated above, there are still no formal legislative regulations on the usage of seclusion and restriction in the United States. There has been long-standing research surrounding the topic of seclusion and restriction in regard to treatment interventions. One study in particular that used response restriction was McEntry and Saunders. The investigators sought to replicate the Green and Streifels response restriction experiment. In this experiment, the research used a reversal design in which there was 4 different conditions and materials were moved based on baseline rates of stereotypic behavior with those materials. The results suggested that, contrary to belief at the time, which was that individuals with intellectual disabilities do not engage in stereotypic behavior without materials because they are restricted from the availability of materials. If analyzed in the same manner as myself, the reader should take into consideration that stereotypic behaviors still occurred when items were both restricted and not restricted. Therefore, in this case, restriction did not show to be an effective tool. In an article that addressed the misuse of seclusion, specifically timeout, Delaney, 1999, stated that it can be often that timeout, or if just an excessive seclusion where the client's placed in a room, If it's overused, red flags should go up as a warning that there is misuse by staff. He also stated that when seclusion is used, it is behavior suppression, not behavior extinction, and there will not be a long-term effect of behavior reduction. Wadden, 1993, compiled an annual on caloric restriction of obese individuals. He claimed that while moderate and severe caloric restrictions did indeed reduce weight, the individuals eventually regained all of their weight back. In other words, the use of caloric restriction worked in reduction of weight for short-term effects. However, long-term effects it did not. While these interventions seem most appropriate and are meant to increase overall health and reduce risk of several health issues, the use of restriction might not be the way to go. One might be able to consider alternatives such as ACT, which is acceptance and commitment therapy, which would allow for a least restrictive alternative in which the client could find their values and then make committed actions in line with those values in order to hopefully produce a long-term effect of weight reduction. To add to the long-standing research, Harris 1996 evaluated 3 methods of restraint used to treat individuals diagnosed with intellectual disability. The 3 methods assessed were the therapist holding the client, 2, a mechanical device used to restrain the client, and 3, the client voluntarily applying the mechanical device to themselves or physically restraining himself or herself by using the client or the staff's hands to restrain him. To begin, the author addressed the 3 problems with using restraint as a method of control. One was that it interferes with ethical standards, as well as it might be considered illegal in some ways, and there's not enough research that shows the long-term effectiveness of restrictive procedures, as well as 3, the side effects to the client and the staff who are implementing restraint as a procedure. Harris 1996 proceeded to review the literature surrounding restraint as a restrictive procedure. The author points out and highlights a major point, which is that restraint restricts access to a large range of reinforcers that are readily available to all other humans. He also said that it brought up more questions than it did provide answers. It should also be noted that there are methods to de-escalate a situation so that restraint does not need to be implemented. An example of a restraining procedure that can also be used to de-escalate a situation can be referred to as the crisis prevention intervention, better known as CPI. It's a type of training that an individual participates in to learn procedures to safely restrain a client in a crisis situation. Jim Benathan and Belair in 1996 compiled an article where they looked at the techniques of using CPI. Results showed that staff were able to effectively reduce the crisis situation in 84.2% of cases observed without having to incorporate a restraint. The results suggest that there are ways to identify and de-escalate crisis situations before utilizing a restraint, which is looking at the antecedents that occurred prior to the behavior. There have also been studies addressing the possible alternatives to using restriction and seclusion as treatments. In a study conducted by Kanito, Valimiki, Putkonen, Kausiminen, Scott, and Hoff, the authors sought to evaluate if there were ethical treatment alternatives to restriction and seclusion. They did this by organizing 3 focus groups, each consisting of nurses and physicians who have used restraining procedures. They utilized open-ended interview questions where they examined the nurses' and physicians' decision-making processes before, during, and after seclusion. They also asked the participants to consider the ethical principles that guided their decisions when they were to treat an individual whose behavior was becoming more aggressive. To continue, the participants were able to come up with alternatives to using seclusion and restriction, which was 1. Nursing interventions, 2. Multi-professional agreements involving the patients, and 3. The use of authority and power. The best alternative, as I would see of greatest importance, is the alternative of multi-professional agreements. involving the patients. This alternative allows the patient to discuss their treatment beforehand and what they think is best, which the nurses and physicians would consider these opinions from their patients as valuable information in considering treatment options. A similar study to the one before is a study by Valenkamp, Delaney, and Verraggi, 2014, in which the authors had a similar research goal, which was to find alternatives to seclusion and restraint, and or to reduce the use of seclusion and restraint in treating patients with aggressive behavior. The authors reviewed the literature that demonstrated empirical evidence of using restriction as a form of treatment, and their findings suggested that there is not enough research that demonstrates the reduction of restrictive procedures. Therefore, there is a need for research in an underdeveloped area of interest. While it is important to identify alternatives to seclusion and restraint, there also needs to be great emphasis on the analysis of events that occur before seclusion and restriction are utilized. Knight 2011 attempted to identify the precursors to seclusion or restraint. The analysis demonstrates the need for a more systematic analysis of behavior that occurs before the emergency crisis situation arises and restraint or seclusion are used. Moreover, studies like these suggest there are in fact alternatives and ways in which to reduce restriction. However, research is limited. Going forward, it would be of great benefit to conduct further research in this area, and as a result, the findings might aid caretakers and interventionists in selecting treatments for individuals that begin with a pre-assessment, whereby a systematic analysis is conducted. Overall, the purpose of this paper was to examine the negativity surrounding seclusion and restraint. While I've done so, it should be noted that my ideas and the research regarding this topic are not exhaustive, and there is a gray area to be considerate of. To conclude, seclusion and restriction might be effective short term. However, there is not evidence that suggests long-term behavior reduction. Also, if there are long-term effects, those effects might arise, but they might be negative for the staff and the client. My recommendation to address the problem of crisis situations in which behaviors are severe and there are not alternatives is to 1. Clinicians should always use least restrictive procedures first and use methods that are standardized in which to de-escalate a situation, such as the antecedent information provided by CPI. And 2, scientists need to evaluate these reported crisis emergency situations, specifically precursors, and provide techniques to systematically analyze a situation to identify those antecedents. To add, as scientists, it is our responsibility to conduct more research and to analyze situations stringently to protect our clients. Hurt, Diericks, Dementer, and Querel 2011 compiled a systematic review of restraint and seclusion with psychiatrically ill youth populations within the last 10 years and found there were few studies that noted precursors that led up to staff using restrictive measures. This is important to note because we have to find these antecedent variables so that we can try to de-escalate a situation before it even occurs, so that restraint and seclusion do not have to be used. Also, to add, we need to advocate for policies, regulations, laws, and more guidelines in this area. As clinicians, we have the responsibility to protect our clients, and we need to take the initiative to advocate for regulations of restrictive procedures to both protect our clients and ourselves.